magnitude of this problem. Please, Professor Sheashaa.
So I will for this nice introduction. In the next 30 minutes, I'm going to discuss with you the magnitude of the problem of interstitial disease and renal dysfunction. I'm going to discuss this topic under the following sectors: epidemiological points, what about the outcome, some points related to the vascular access. When to start the dialysis is a very difficult question. What should we do for these patients? To start with, regarding the epidemiology, if you look at the last report of the United States Renal Data System, you will find that through the years from 1996 till the current data, the number of patients treated with interstitial disease are expanding. So if you look at the blue line, which reflects the number of patients treated with hemodialysis, on 1996, the number of patients at the United States of America was 200,000 patients. After 17 years, and the current data, these 200,000 patients increased to more than 400,000. This means through these 17 years, the number of patients treated with hemodialysis was doubled. And this slide also shows not only the prevalence, as shown in the previous slide, but also the incidence. Incidence means new patients treated with dialysis. So, as well, the incidence is tremendously increasing over years. What about the age of patients treated with dialysis? No age is exempted. If you look here to this brown colored line, you'll find it increased, and this brown color line reflects the patients on the productive age from 45 to 64 years. Not only this sector of patients, but as well the two extremes of age, elderly and young age patients are increasing. So dialysis is increasing respective to the age sector. And this is the prevalence, per million. Regarding the etiology of interstitial disease, the known etiology in the United States of America and in many countries, the major causes are these four causes: diabetes mellitus and its complications, hypertension, glomerulonephritis, and polycystic kidney disease. So these are the most common four etiologies for interstitial disease. All countries witness this problem. So the problem is present everywhere. And according to the available data, this figure shows the prevalence, and this shows the incidence, and these are the name of countries. And the top four countries are Taiwan, Japan, United States, Singapore. And you will find some African and Asian countries through these lines. This is a very important map because it reflects geographic variations in the incidence of treated interstitial disease per million population by country, and this is according to 2013 data. If you look at the map, you'll find Africa is colored white. White here is not good. Why? Because there is no reliable data coming from African countries. So we are in real challenge to have data. Because if we don't have our own data, how can we manage the problem? And currently we are working in Egypt to establish Egyptian renal health system, and this is with collaboration of many doctors all over the countries, and through the Egyptian Society of Transfusion and Transplantation. And my colleague, I am honored to have my colleague, Dr. Tawtal, who is responsible to collect and collaborate the coordination of data collection from the center, from institutions. So we have institutions and we have private centers to collect the data. And I'm dreaming and I'm hoping to have the day that we can say accurately what is the problem, volume, and the magnitude in our country. We can find in the literature some sparse data. This is one of the publications of Professor Sheashaa regarding the etiology of chronic kidney disease in North Africa. You can find here 3 countries: Egypt, Tunisia, and Morocco. And this is the different etiologies. Glomerulonephritis, diabetes. Here the hypertension is the leading cause in Egypt, according to the Egyptian Society of Transfusion and Transplantation. Again, the data is not so accurate. But I want to stress upon interstitial and other unknown causes, because these are very important to educate the people to avoid the use of drugs and to avoid the use of herbal remedies and to combat infections and dehydration. One of the most recent and interesting data came from this publication, a systematic review of all publications that discussed the CKD of uncertain etiology. And these are the countries from South Asia, Central America, other regions, including 2 African countries here, Tunisia and Tanzania. And among the etiologies that can explain chronic kidney disease in these countries, as you see here, the exposure to heavy metals, dietary exposure, heat stresses, and use of drugs. So we should be careful about drugs and environmental factors that may lead to increasing prevalence and incidence of chronic kidney disease. Regarding the outcome, this one of the recent publications showed that uremia affects all body systems. No single body organ is exempted. So you have here the manifestation of chronic kidney disease, anemia, immune dysfunction, osteodystrophy, hyperparathyroidism, insulin resistance, malnutrition, inflammation. And malnutrition and inflammation are very important because they share in killing the patients. Coagulation disorders, skin atrophy, pruritus, gastrointestinal disorders, cardiac failure, bronchitis, anorexia, pericarditis, hypertension. So nobody is exempted. So uremia affects the whole human body from hair to toe. And currently there are more and more new hot topics in dialysis. One of the recent, we are acquainted with intradialytic hypotension, but the title is intradialytic hypoxia. This is a very smart publication because they looked at oxygen saturation during dialysis minute by minute, and they found that there is some patients suffer from intradialytic hypoxia. And the presence of intradialytic hypoxia is associated with increasing mortality. So a lot of new factors are added. Sudden death is terrible because the major cause of death in dialysis is sudden death. And to know why sudden death occurs, there are many speculations. One of these speculations is arrhythmia. And this is a protocol that tries to fix the occurrence of arrhythmia by introducing a base, introducing catheters, and to monitor arrhythmia by the computerized method. So we are waiting the result of this study. Again and again, the use of dialysate dialysate potassium level, for example, when set very low, this may be associated with sudden death on dialysis because it leads to arrhythmia, especially if it is associated with aggressive ultrafiltration and aggressive or many other electrolyte disturbances like hypocalcemia and hypomagnesemia and metabolic alkalosis. So we should be cautious about all these factors. This is one of the depressive slides. Why? Because if we look at the 5-year survival, this is the 5-year survival of hemodialysis patients. Look here, the survival of dialysis patient is even lower than patients with prostate cancer, cervical cancer, breast cancer. So we should do something to improve this outcome. Again, this is the mortality according, if you look here in comparison to transplantation, the mortality in dialysis is significantly higher. This is a teaching point, because if we have a dialysis patient who is fed for transplantation, we shouldn't deprive him from this service, even we can say to him where to have the service of dialysis, of transplantation, sorry. And this is one of the best articles that shows that if you compare, this is a kidney transplantation, if you compare survival of the patient who are transplanted, the median survival is 12 years, and for patients who waited on dialysis, the survival is 5 years. So there is survival advantage for transplantation. Again, if we look at this data, the major fraction of mortality occurs within the first year, especially during the first 3 months of dialysis. And the question why? This reflects the poor pre-dialysis care. And this reflects the use of, for example, catheters to do dialysis, because catheters are associated with infection, and infection is associated with higher mortality. And this is the comparison again, that this is regarding hospitalization between hemodialysis, peritoneal dialysis, and transplantation. In comparison to transplantation, hospitalization because of comorbidities is more common in hemodialysis and peritoneal dialysis in comparison to transplantation. The cost through the years, through 1 decade only, the cost is doubled from $15 billion in the United States to 30. So again, not only mortality, hospitalization, morbidity, but also higher cost of taking care of these patients. And this is a comparison of the different renal replacement therapy modalities regarding the cost. If you look, hemodialysis is the most expensive here in the United States. In our country, the peritoneal dialysis is more expensive than hemodialysis because we don't have fluids or we don't have factory for these fluids. Transplantation is cost-effective in creating end-stage kidney disease patients. And this is some data from the Ministry of Health from Egypt. The total annual cost for treating end-stage kidney disease consumables 1.8 billion Egyptian pound, and this constitutes 12% of the total annual budget of the Ministry of Health according to 2012 data. Regarding vascular access, the problem is how to initiate dialysis, through which route. Here, if you look at this, the green colored line here, it is not green, it's not good, because 2/3 of patients are dialyzed or starting their dialysis through catheters. And this colored line, this is the some patients need catheters, so the total catheter use is approximately 80% of the patients. And here, this is through the prevalence dialysis, so the initiation usually with catheter, but after that, fistula is created. So here you can find the majority of patients are dialyzed, the prevalent dialysis patient through fistula. the decision. This is one of the important clinical questions. When should I say to the patient, we need fistula for dialysis? When we have pre-dialysis care and follow-up of this patient, we should determine the time, the proper time for advising of fistula. The decision, according to this publication, we should put all these things together. Clinical parameters, prognosis from the renal perspectives and the patient perspectives, and vascular anatomy. All these should be mixed together in a wise manner, because if we have aged patients with multiple comorbidities and we expect short lifespan, I think the graft or permicath are suitable, and catheter and fistula is not suitable for these patients. Or if we have a patient young in age with fast pace of progression of chronic kidney disease, fistula is the best. But if we are dealing with a patient with slowly progressing chronic kidney disease, we can wait instead of advising for fistula and until we feel that we are approaching dialysis. Because of appearance of symptoms, we may have graft here in this situation. So this is the map that we put together with the patient, but we should discuss with the patients, because this will be in the patient perspectives and the patient-centered approach. And in this course, we have a new lecture entitled Patient-Centeredness Care that will be offered by my colleague, Dr. Ahmed Abdul. Regarding the different vascular access, from the Italian perspectives, this table summarizes pros and cons of each vascular access type. Preemptive AV fistula, this means to do AV fistula before starting dialysis, and AV fistula after dialysis. So here the dialysis will start with catheters until fistula is created, AV graft, and the catheters. Here you can find the advantage and disadvantage of each modality. And this is one of the most important slides, because here the advantage of the fistula, no age limit of this procedure with adequate vessels, lower infection rate compared to catheters and graft, and maybe better survival, and the patient can take his shower. The disadvantage is combating the risk of death before hemodialysis start, high rate of failure of maturation. This is the most important in dealing with elderly patients. And here the catheters are associated with high rate of infection and the higher morbidity and mortality. We should take care of catheters. When we are obliged to start the dialysis with catheters, we should take care of catheters by full aseptic technique and by using antibiotic lock solutions or antimicrobial. Antimicrobial is better than antibiotic because antimicrobial lock solutions are devoid of development of antibiotic resistance. However, if we have these criteria, there is no way catheters should be removed. Infections with Staphylococcus aureus, fungal, mycobacterial pseudomonas, persistent fever and bacteremia, 48 hours to 72 hours of systemic antibiotics, hemodynamic unstable, toxic, a very patient, metastatic infection. This is very important because you may have a patient with septic arthritis and you deal with septic arthritis and there is catheter. So long as catheter is there, septic arthritis will not be cured. So in management of septic arthritis, we should remove the catheter. Exit site of tunnel infections, so these are indications to get rid of catheter and to treat the infection appropriately and to rethink of what you will do. We want to start the dialysis in a fast way. The best is to look at the patient as one unit. So we don't dialyze serum creatinine. We don't dialyze laboratory figures. We dialyze the patient. So we should look at the laboratory parameters, the patient, the progression of the kidney disease, the age of the patient, and the development of symptoms. And we should be careful if we selected conservative treatment is to avoid malnutrition. So this is the plan. This one from multiple trials showed that there was no difference if we started dialysis in this range of GFR, estimated GFR 10 to 14, or 5 to 7, so long as the patient's symptoms are compensated. Here the trend in the United States, in the early part here, start dialysis late with the GFR less than 5, and then in the midway here, the tendency was to start dialysis earlier, and then currently they are thinking of little bit later dialysis. Here the answer, it is early or late dialysis. It is neither early nor late. It should be on-time dialysis. And this is the same guidelines from Kuduki last year. The working group favored an individualized approach to timing dialysis initiation. Individualization means to look at the age, the laboratory parameters, symptoms, and symptoms are very important and crucial, and the malnutrition, all these together. By analysis all these factors, I can determine the best timing for dialysis. And again, currently in this year, a lot of discussions in the paper regarding initiation of dialysis for senior patients, and I think I'll discuss it in the lecture of the ethics in this night. So to dialyze or not, still the question is valid, especially for elderly, because it's a summary of all studies showed that for elderly patients, there is no superiority of dialysis over conservative treatment. So we'll discuss it in the afternoon. What should we do in 2 minutes? We should early interfere with the patient. We should have proper pre-dialysis care. It is very bad and shame for all of us to have these calcified vessels. If we wait until the vessels are calcified like this, the patient will eventually be lost. To have our own guidelines, and this is a sample of guidelines from Egyptian Society of Nephrology, how to take care of vascular access, from evaluation to periodic checking. So this is a very nice. And the most important is to have coordinated care, not fragmented care. And this is one of the focus of quality assurance in dialysis unit. And today, Professor Samir Samli will give us his perspectives about quality assurance in dialysis unit after this presentation. And this is the goal of safety, or the safety environment, or the aim of quality assurance, and this is the current version on March 2016, is to have, all of us need better care. And all of us like to have all care affordable and seeking for the healthy people. So this is the triad. And we should deal with all these fragments. And I think Professor Samir will discuss all the issues regarding the quality. For myself, I enjoyed the visiting in many countries in the African countries. This is in Lagos, Nigeria, Rwanda, Sudan, Ethiopia, and this is here, and the last course, and this is on December, last December, we have many guests from different countries, and they were interactive. So I hope that you will be interactive like these doctors, and here the how they ask, and we have Dr. John today, like we had him in the last course. So we thank him for suffering of live translation for the fast speaking doctors. Again, this is the last December, and this is one of the award or gift that I give to all the nephrologists that attended this course, to have a membership through the Egyptian site of Nephrology Virtual Academy, and you will find here you will find a wealth of lectures, because we have currently 2,160 lectures and more than 1,120 videos for the nephrology. We have users from all over the world, 26,000 users. And if you log into this virtual academy, you will find even that this lecture is already uploaded, and the all presentations will be uploaded to this site. Finally, we seek for success. And success means to have a success, you should see your goal, understand the obstacles, create positive mental picture, clear your mind of self-doubt, embrace the challenge, stay on the track, and show the world you can do it. And this is through collaboration. Collaborations divide the task and multiplies the success. And thank you very much for your attention.